fill in the paper version that has been distributed to you. In an effort to strengthen our move towards paper-smart meetings, we encourage completion of the online version, which can be found on the conference website www.getinthepicture.org. We recommend that you complete the questionnaire at the end of the conference. However, if you are leaving the conference early, we ask that you kindly complete the questionnaire prior to your departure. And if you are using the paper version, please drop your completed questionnaires in one of the boxes located near the exit door. Thank you for taking the time to provide us with your feedback. It is now time for the second of today's special sessions, Strengthening Vital Statistics Systems, Strategies to Improve Knowledge about Causes of Death in Asia and the Pacific. This session has been organised by the Asia Pacific Observatory on Health Systems and Policies, and it is my pleasure to turn over proceedings to Dr. Dale Huntington, the Director of the Observatory.
Thank you, Aaron. Welcome, ladies and gentlemen, to the 1 o'clock session. The Asia Pacific Observatory is very grateful for the organizers to allow us to pull together this session for the launch of one of our newest publications, a policy brief followed by a working paper. The Asia Pacific Observatory, or the APO, is a relatively young organization. So with your permission, I'll take just a few minutes at the beginning of the session to give you a bit of an overview of who we are and what we do, and then we'll pass the baton to our main presenter. The APO is a collaborative program hosted by WHO. We sit in Wipro, but we cover both Wipro and CIRO. We're a membership organization. We have governments belonging to us: Hong Kong, Korea, Philippines, Singapore, Thailand, Bangladesh, Myanmar. We have international agencies: Asian Development Bank, DFAT, AUSAID, World Bank, WHO, CIRO, and Wipro are both formal members. We have a broad footprint through the research community, universities and institutes throughout Asia and the Pacific region. We aim to be a knowledge broker. We aim to promote evidence-based health policy. And so we bring together researchers, development partners, and governments in a variety of forums, much like we are doing today. We produce high-quality evidence on health systems to inform policy. We put the emphasis on quality. We want to build our reputation around a reliable, credible source of information on pressing issues, both of national concern and regional. We also have a very strong capacity development lens to all of our activities. We're structured a bit as a special program usually is within WHO. We have a board of our members. I have a strategic technical advisory group that helps fashion our agenda, and that group identified last year the importance of civil registration and vital statistics for the APO to put together a policy brief on. There's a small secretariat, and we have a research hub and network members that does the bulk of our research. These are the research institutes and affiliated institutions scattered throughout the Asia Pacific region. And in fact, Professor Lopez is the director of the research hub based at University of Melbourne. What do we do? Well, we have some products. We do Health Systems in Transition, or HITS. These are comprehensive reviews of national health systems. Comprehensive is the operative word, both public and private sector, all services. These are standardized, template-oriented reports, so they're comparable across countries and within a country over time. We've currently produced about 10 hits, and we have another 15 in the pipeline. So if you ever need any information, say, for example, of Myanmar, go to the APO website, and you can have a very comprehensive overview of what that health system is doing, how it's structured, how it's financed, and what are the key reforms that are at play in the country. We do policy briefs. The session today is the subject of one of those policy briefs. And we also do comparative countries case studies on issues for which there perhaps isn't enough evidence base. Those are published as books. We'll have books coming out on public hospital governance, case-based funding mechanisms, strategic purchasing, and also NCDs and rapidly aging societies. We also have some practices. We fund postdoc fellowships. We have a collaborative program with Stanford University. We also place fellows within region, within our network. We have approximately 4 fellows right now placed, and we put out call for applications of our fellows regularly. We sponsor policy dialogue events and seminars. Here are some of the policy briefs that we produced, and today we're talking about vital statistics and the importance of civil registration of vital statistics with the perspective of reducing uncertainty about causes of death in the region. We have a few that are forthcoming. I'll just lay them out here for you, okay? So that's the Asia Pacific Observatory. Thanks very much for giving me the opportunity to give you a short orientation to who we are. Please visit our website and like us on Facebook, and you'll be sure to get continuous updates on new products as they come out. So with those few words, I'll pass the microphone to my colleague, Professor Lopez, for the presentation. Thank you.
Very much, Dale, and good afternoon, colleagues and many friends. It's actually a personal pleasure for me. I was part of the group who started this process in this regional office about 5 or 10 years ago, and it's wonderful to see it come to fruition with so much participation at such a high level. So I'm personally delighted to be here, and also to thank the Asia Pacific Observatory and the organisers of the conference for the chance to talk to you about hopefully a subject that is not foreign, but is indeed central to all of the things you are doing in countries about health and social development. I'd like you to think it is. This slide probably summarises it all. A lot of what you have been focusing on, correctly so, in the last couple of days, indeed, the last couple of years, is about the rights of children, about birth registration being fundamental as a right of the child. Well, it is. But surely the right of any child is to expect to survive to adulthood and then on with a productive life into old age. How can we assure that right of a child to survive? It is about health system responses, policy responses in your countries that are informed by evidence. What is the right evidence that you need in your countries to guarantee that your children do survive? That evidence, ladies and gentlemen, is causes of death. And it's reliable information about who is dying of what in your populations and how is that changing. That is what this policy brief is about. It's in response to that question that many countries are asking the World Health Organization and other development partners repeatedly. What can I do? I'm a poor country, or I have limited statistical capacity. What can I do to rapidly improve, in a cost-effective way, knowledge about causes of death in my population, to better inform policy? Indeed, health systems, sorry, I'll get this right in a moment, health systems and health policies ought to be informed by fundamental health intelligence, namely your health information system. What is the cornerstone of a good health information system in any country? It's information from the civil registration and vital statistics system about births, about deaths, and about the causes of those deaths. And that's what this policy brief is going to focus on. Just very quickly to introduce it, the policy brief that Dr. Huntington showed a moment ago proposes a number of strategic frameworks to respond to this challenge of causes of death. It focuses on practical interventions in 5 distinct areas, and I'll introduce those in a moment. And it suggests a series of specific interventions, not waving our hand saying we should do A, B and C generally, but specifically what can we do at different levels of health statistical development, and we classify 3 broad levels of health statistical development. That's the policy brief that has been launched today and should be available for collection. I urge you all to study it, both the hard copy and, of course, the online copy that's available as well. What are we trying to address here? What's the problem in countries that needs to be strengthened in terms of a vital statistics system? And the ultimate goal here is any country, Bangladesh, India, Myanmar, Sri Lanka, any country in this room can rely on cause of death intelligence to be guiding their health information system, to be guiding their health system and policy responses to improve, but not only child health, maternal health, and of course adult health. So that cause of death information traditionally comes from 2 sources. The source we're most concerned about is a civil registration system which yields fundamentally important vital statistics. We call it the CRVS system. That is informed by deaths from hospitals. These are deaths in hospitals based on medical records. MR is my abbreviation for medical records. Are these deaths correctly certified? I'm going to answer that question in a moment. They are a fundamental input into any cause of death system in your countries. You also have death certificates from GPs that are not connected to hospital deaths feeding in. This is all, in principle, correct and good. You then have a vast number of deaths, more in some populations than others, that occur outside of hospitals. Do we throw our hands up and say, well, no way we can get causes of death for these deaths? Wrong. We now have technologies and methods that are cost-effective to do so. And this is primarily what I'll introduce later, and that's written up in the policy brief, the technique of verbal autopsies. I'll define that in a moment. We can apply that to deaths outside hospitals and integrate it into the civil registration system. We have fundamentally ignored the importance of verbal autopsy as an adjunct to a good civil registration system for getting information reliably and cost-effectively about causes of death that occur outside the medical system. Unfortunately, there are still many causes that do not have verbal autopsies, and at the moment, these causes of death go either unrecorded, unregistered in your populations, and hence we have no idea about the causes of those deaths to inform policy responses in your countries. We are trying to minimise these. We are trying to improve the accuracy of this system here. How well are you doing in this region? Well, you might think you're doing well, you might think you're doing less well. There have been studies, and I have been behind one of them that I'm reporting here, which have developed objective methods that don't require any opinion from the countries, but look at the quality of the data. And we call it a Vital Statistics Performance Index, a VSPI. And we have graded countries in this region based on the publicly available data that countries make publicly available to organisations like the World Health Organization and the World Bank and so on. So we've graded countries according to the scheme here, red being very weak civil registration systems, weak, medium, good and very good. There are only 4 countries in this region, Australia, New Zealand, Japan and South Korea, that are classified according to this index. Completely objective index. Nothing to do with subjective opinion from us or countries. 4 countries that we would classify as having functional, useful, vital registration systems that are good for policy. We have another 2 countries, Singapore and Malaysia, which are doing well but could do better. There are some significant problems in those systems. Philippines, Thailand, Maldives have systems that are of medium quality but have a number of problems with regard to data, particularly causes of death. Brunei, Sri Lanka, Fiji, China are in the next category. And then weak systems, you can see, I'm sorry the red is not showing up the countries, but you can read them there and read them in the policy brief. More importantly, there's a whole vast number of ESCAP countries for which we have no public information whatsoever on vital registration and causes of death, and hence it's very difficult, impossible indeed, to assign a score to those countries. So coming back to that's the situation in the region. I hope you will all agree with me that is a deplorable situation for vital statistics, given its fundamental importance in guiding policy for health and social development in your countries. What might we do about it? And that's what the framework addresses. We look at 5 critical areas, the 5 aspects of the framework that we suggest need urgent attention. Firstly, before you can classify the cause of any death, you need to register it. And this, I know, has been the subject of your conference so far, and I can only urge you to focus on registration of deaths. I'll come to that in a moment. Medical record practices in hospitals. Very few people pay much attention to this, but without fundamental information about the patient care, about the illnesses, about the clinical the records that are associated with patient care in hospitals, it's very difficult for physicians to certify. And that's the next thing that we need to strengthen. The practice, the critical practice of doctors in your countries certifying the cause of death will show how badly they're doing. Then we then need to be able to have trained statistical staff take those death certificates and code them according to the standardized rules and procedures of the International Classification of Causes of Death, which is maintained by the World Health Organization. And then finally, the fifth platform that we're going to address is how can we diagnose with reasonable accuracy the cause of death of those deaths that occur outside of hospitals and medical settings in a reliable and cost-effective way. So I'm going to present to you three broad challenges that summarize those 5 areas. Firstly, how can I improve the registration of deaths in my country? I hope you'll all agree, without even registering deaths, you don't even get to the first step of a policy information system that will help guide policy development. So what can we do? And I'm not going to focus on this very much because there's many of you in the audience who are more expert in this than I am, and indeed I'm sure this has been part of your discussion. But by now we've a number of strategies that exist for improving the completeness of death registration and notably here avoiding duplication of effort. Let me repeat that, avoiding duplication in effort. In how many countries in this room does the Ministry of Health and the National Statistical Office and the National Civil Registration Office all register the same death? You all spend resources doing the same thing when you could be more effectively using those resources on other aspects of the civil registration system and vital statistics system. There is a clearly defined regional strategy that colleagues in this room have been working with collectively with countries. It's an excellent strategy and it lays out mechanisms to support you to improve registration. There are a series of tools available now that countries can use to assess your gaps in systems. Many of these came from the UQ, University of Queensland, Health Information Systems Knowledge Hub in collaboration with the World Health Organization. They are available and still applicable for use. There's a comprehensive resource kit. It's available for you. Don't leave without it. It's available here. It's 250 pages. It's also available online. It will direct you to the answers to your questions about what I should be doing to improve a specific aspect of my vital registration system. I'm urging you to act now. You're in this room because the regional momentum is strong. It has never been strong in my 4 decades of engagement in the vital registration area. It has never been this strong. It's not just in this region. It's the same in Africa, the same in the Middle East, the same in East Asia, the same in Latin America. It's a wonderful time, given the high-level political commitment, to make a difference to these systems. So the second major strategy is a very complicated one. What set of strategies what set of strategies can we employ to improve cause of death information in countries? There are 3 things that will need to improve. Cause of death medical certification. Notice I stress medical certification. Only doctors in your countries should or could have been trained in the correct certification of the cause of death. I can't do it as a statistician. Nurses can't do it, allied health workers can't do it, only medical doctors can correctly certify causes of death. How good are your hospital medical records? Do they need to be improved? How efficient are your cause of death coding processes in countries? And indeed, any set of strategies to improve causes of death needs to respect system thinking. Here we have hospitals where we have medical records, the fundamental ingredient that guides doctors in hospitals about medical certification ought to be good medical records on patients. That leads to doctors filling out correctly the sequence of events that led to the patient's death. They may not have been able to prevent it, but they can contribute vastly to our public health resource base by correctly certifying that sequence of events. Train statistical clerks, not doctors, repeat, not doctors. This is a waste of doctors' time to code those certificates based on the ICD principles that are in place. And finally, statisticians routinely, in a timely fashion, taking information and compiling cause of death statistics to guide policy development in your country. So 3 very quick strategies. 1, to improve medical records procedures. We lay out a series of strategies in the policy brief. But if medical records in hospitals are not accurate, up-to-date, complete and easily retrievable, then patient care, hospital management and planning, as well as health statistics, and particularly cause of death information, will all be severely impaired. They will be much less efficient and much less accurate than they could be. So this set of criteria are critically important for managing medical records. And we lay out a couple of strategies. The framework lists 10 key actions to improve medical records in hospitals. This may seem obvious, but countries are not doing this. In every country that we work in, we find medical records in a deplorable state. They're valued vastly underutilised and underappreciated. Ensure national standards and procedures and policies are in place for medical records. Review your patient forms that are used all the way from admission to discharge to make sure they're fit for purpose. Provide training to medical record staff, and so on. You can go through and see the various applications. These are just a summary of some of the 10-point plans. Strategy number 2, if you've worked on medical records, what can you do to improve their use in medical certification? So I hope it's clear that death certificates are the most important source of cause of death data. They are critically important that the cause of death information is certified by a doctor. Again, not by allied health personnel, not by the village chief, not by a policeman, but is certified by a medical doctor who ought to have been trained in medical school about how to do so. Only doctors are qualified to identify the cause, the underlying cause and the sequence that led to deaths. So deaths that take place in hospitals, we would imagine, in principle, are medically certified and hence they're assumed to be correct. But closer examination often reveals, as I'll show in a moment, substantial misdiagnosis even in hospitals. You are all relying on hospital data saying these are correct. These are telling me what the leading causes of death in my population are. And, that is likely to be incorrect. Why is this incorrect? Well, doctors don't always have the tools, the medical diagnostic tools to help them certify deaths correctly. More likely, they have had no training or poor training in cause of death certification in your medical schools. And they lack understanding about the public health importance of what they are doing, that is, certifying deaths in hospitals. More broadly, physicians often have never been taught how to correctly certify the cause of death. They've never been taught. I find this in country after country that I work in. The medical records that they're going to use to certify causes of death are often too poor and too incomplete to be useful. No one is correctly maintaining medical records in hospitals. So the death certificate that you're using in countries is often not aligned with the international certificate. The international certificate says, what is the underlying cause that led to this disease, that led to this disease, that finally led to death? We are not interested in public health for prevention on the immediate cause of death, pneumonia, septicemia, heart failure. That is irrelevant. What is relevant is the underlying cause, like lung cancer or ischemic heart disease or stroke or diabetes or measles, that led to the final cause of death. And then poor coding practices to select the underlying cause of death also lead to misdiagnosis, poor coding practices in hospitals. So the takeaway message from this, and this is shocking but true, cause of death data in your populations, even my country, Australia, will always be wrong because of that plethora of factors. But it's important for public policy to know how wrong they are if we are going to use them for the policy uses they're intended for. So we do studies where we take a sample of hospitals and hospital deaths. We go and look for the medical record. We use that medical record with an independent team to get the underlying cause of death. We compare it to the original cause of death in your national vital registration records. We develop a misclassification matrix that shows not only the extent but the pattern of diagnostic errors, and that leads to corrective action. Much of your regional strategy is focused, or should be focused, on corrective action in hospitals. And here's an example for Thailand. I don't know if we have a Thai delegation in the audience, and I'm not picking on Thailand particularly. This is absolutely typical of what we find in countries. We took a national random sample in Thailand of 3,316 deaths. We looked at the vital registration diagnosis of those 3,000 deaths. We then compared them to the medical record diagnoses, which are the various columns. If the medical records and the hospital's vital registration were correct, all the deaths would lie on a diagonal. Do they lie on a diagonal? Absolutely not. They're all over the map. So let's take, for example, cerebrovascular disease, which according to the vital registration killed, this is stroke, killed 262 people in this sample. But if we go here and look at what the doctors say after reassessment, it's 386, or almost 100% more deaths, and so on and so on. Septicemia, absolutely useless for public policy in preventing causes of death and preventing avoidable deaths in your population, was the cause of 470 of your causes of death in this sample in Thailand. But look at important contributions to cause number 52. 53 of those septicemia deaths were actually diabetes. 55 of those septicemia deaths were actually cases of stroke. If you are not getting the underlying cause of death correct in your population, you are doing a disservice to public policy in your countries to correctly certify deaths and to affect the policy action that you need. So strategy number 3, improve. That was strategy number 2, that was cause of death certification, improve cause of death coding. When the quality of coding is poor, countries often blame poor coding practices. But often we're blaming the wrong person. Those statisticians and clerks who are entrusted with coding the death certificates from doctors can only code what the doctors write on the death certificates. And so coders cannot select a valid cause of death if the information provided by doctors is poor, incomplete, I should also put inconsistent here, or ineligible. So periodically we need to do coding evaluation to assess how much of the error is due to poor doctor's practice, how much of the error is due to poor coding practice. And we lay out in the policy brief a series of actions which I've summarised on this slide to improve cause of death coding. One of them I'll just point to here. It is important that countries undertake regular coding audits where you take a sample of death certificates and you have them recoded to ensure that the quality of your coding is as you would like it to be and coding is fit for purpose. The third major challenge, the one about causes, what do I do about deaths that occur outside of hospitals? So how can I get useful information on causes of deaths when the deaths occur outside medical systems, particularly at-home deaths? And I'm sure this is a question that many of you are having to grapple with. And here I'd like to introduce this concept of verbal autopsy and its integration into CRVS. Currently, verbal autopsy is primarily used in countries around the world, including in this region, as a research tool. But it has much greater potential for strengthening civil registration systems in terms of causes of death. So verbal autopsy, in my view, is the only viable option in the short term for countries that are unlikely to get full medical certification in our lifetime. What can you do? And my strong advice is to apply verbal autopsy, particularly the new methods that are coming out. Verbal autopsy is a method which assigns a probable cause of death from an interview with the family. You go to the family after a decent interval of mourning. You ask a series of structured questions, plus open-ended questions, about signs and symptoms experienced by the deceased, and you have those reviewed. Now, the traditional practice has been to have these signs and symptoms reviewed by a medical doctor. The problem about using a medical doctor, as I'll illustrate in a moment, is cost, timeliness, and non-standard review of death certificates. So there are two basic components in a verbal autopsy: the questionnaire that you use to ask the family about signs and symptoms, and the diagnostic method that you apply, doctors, or as I'm going to introduce in a moment, computer algorithms to assign the probable cause of death. A variety of these questionnaires and a variety of diagnostic methods have been used. WHO has been active, correctly so, in trying to introduce some standards for both questionnaires and diagnostic methods. But until recently, there's been no formal scientific evaluation of the different questionnaires and different diagnostic methods, including those recommended by WHO. And for routine application in your populations, you will need confidence about the reliability of verbal autopsy to reasonably reliably describe causes of death in your populations. So countries have tended to resist verbal autopsy for a couple of reasons. Firstly, the length of the VA questionnaire as applied in research typically takes 50 to 60 minutes. That is likely to be too long for routine application to all out-of-hospital deaths in your countries. So we need a shorter questionnaire. Secondly, the cause of death is usually diagnosed by asking busy doctors to review the questionnaires and then to decide on the causes of death. For example, in India, the excellent sample registration system that's operating there asks doctors to review questionnaires. The latest available data from the Indian sample registration system refers to 2003. We are in 2014, about to go into 2015. How can we be making and guiding and informing policy responses in the government, for the government of India using data that's over a decade old? Because doctors are simply too busy to spend the time to reliably review these questionnaires. So more recently, in an attempt to deblock this situation, research has developed automated computer methods which diagnose the cause of death based on symptom patterns in these questionnaires. And this now makes verbal autopsy application affordable in all countries. Just because it's now affordable and easily applicable, is it correct? Is it reliable? What confidence can you have in your countries about the use of verbal autopsy for routine application in your vital registration systems? And until recently, no formal scientific comparison of various methods to diagnose verbal autopsies has been carried out. When this was done and published earlier this year, and I want you to pay very, very careful attention to this conclusion, the surprising finding, even to us who generated it, was that automated methods using computers are more accurate than doctors in getting the cause of death right. More accurate than doctors. We can say that because we went out and collected the true cause of death for over 12,000 deaths, and then we compared the diagnostic performance of automated methods with doctors in various countries, most of which are in this region. But not only are they more reliable, they are quicker, cheaper, and more standardized, since verbal automated methods are not affected by the different diagnostic skills, training, and indeed prejudices of doctors in different populations. And here's an example summarizing what I'm talking about. It's a busy slide, but let me just try to focus on one part of it. Let's just focus on adult deaths. And with healthcare experience, this means adults who died after some contact with the health services in countries. This is based on about 7,000 of those deaths. And along here on the x-axis is the accuracy of that in terms of it goes from a scale of 0 up to 1. 1 would be perfectly accurate. So let's just focus on the top quadrant here. These are deaths where there's been some contact with the health services. In the best possible hospitals, in the richest part of these developing countries, causes of death in hospitals were still only diagnosed with about 85% accuracy. That should not surprise you after I've shown you the data from Thailand. The best automated method, called the tariff method, which associates symptoms with causes of death. If you've got lung cancer, you're likely to have certain symptoms. If you've got breast cancer, you're likely to have certain symptoms, and so on. And the tariff method is based on that signal-to-noise ratio. It is about 80% correct. So the cause of death fraction, the cause of death distribution in rural Nepal, where there may not be any doctors, but applying the tariff method and automated VA, you can get roughly 80% accuracy. Don't take the difference between 80 and 100. Take the difference between 80 and 85, because that's the best you're doing in hospitals. Now, doctors, on the other hand, have about 70% accuracy, significantly worse than that automated method. The other automated method that's widely used and advocated by WHO is called inter-VA, and that's significantly worse than doctors. So there's a group of new methods, tariff, random forest, and so on, that you can see virtually in every one, whether it's adult deaths, child deaths, neonatal deaths, with or without healthcare experience. They are performing better than doctors. That is a scientifically evaluated study and published. It's an exciting period for cause-specific mortality data and its strengthening. Some overall conclusions. Cause of death statistics improvement needs a systems approach which addresses all the underlying subsystems that I've addressed here today. Our proposed framework has key improvement interventions for all of these major component areas that affect the quality of cause of death data, completeness, medical records, improving hospital data. Do not believe your hospital data are correct just because they come from hospitals. There are ways to strengthen and improve those data, make them fit for purpose. We think the routine application of automated verbal autopsy on all out-of-hospital deaths that are recorded is feasible and advisable for you to reduce ignorance about those who die out of hospital, primarily at home. And importantly, we're strongly recommending that a reliable monitoring and evaluation system be implemented to assess the impact of interventions as you go forward. And finally, the policy brief in its summary lists for you and summarises for you depending on the status of your system. So whether your system is classified by us or by you, it doesn't matter, but whether you think it's a weak system, it's in green, we're laying out a Group 1 pathway, a series of interventions for you to follow. If your system has moved on, is weak, but not very weak, then you have a series of interventions, many of which focus on getting the quality of causes of death. You're capturing most deaths reliably, both the age and sex of those deaths in your vital registration systems, but you're not capturing causes of death reliably. Here's a series of interventions to do, listed over here. And then countries which have medium CRVS, not yet good, but could move into the good category, we've listed a couple of strategies down there. Notice that all of those strategies implore you to look at improving medical records in your hospitals, train your doctors in correct cause of death certification, and train your staff in data verification. Data are not useful just because they're there. They are useful when they are verified. Thank you very much.
Thank you, Professor Lopez. The floor is open. Comments? Questions? We have a few minutes left for discussion. Yes? Solomon Islands, the floor is yours.
Thank you, Chair. I'd like to first thank Professor Lopez for his leadership in the establishment of the British Brisbane Accord Group and his technical leadership in the Pacific region. I am from the Ministry of Health in the Solomon Islands. I am not a medical doctor, fortunately. I'm responsible for finance and admin within Ministry of Health. Professor Lopez, as you are aware and you mentioned, Solomon Islands has a weak vital registration system. Our challenge is not just in the registration of births and deaths, but we are confronted with having poor information on the causes of death. From a health system perspective, we are beginning to understand the importance of this critical data, particularly in light of growing crisis of NCD in my country and the region. But you will be pleased to know that as we speak, 20 medical doctors in the Solomons are currently being trained in the proper cause of death using the University of Queensland tool. So my question is, how does a country like the Solomon Islands, given we cannot register every death, nor do we have enough doctors to certify every death, how do we try to extract and strengthen this very critical information? Do you suggest we look at verbal autopsy to get this data, even when our CRVS system is weak? Thank you.
I'll take a few more before we respond. Please.
Thank you, Mr. Chair, and thank you, Professor. That was a brilliant presentation because Malaysia is also trying to improve documentation of cause of death, COD. The first issue that we realized was the terminology that we use when documenting the cause of death. We have the first line which says cause of death and underlying cause of death. And the confusion arises because our cause of death is equivalent to, your cause of death is equivalent to actually underlying cause of death. That has created a lot of confusion in our data, statistics and whatnot. And what we have done so far is to code both and then analyze accordingly. Yeah. And number two, we're also trying to standardize the verbal autopsy, and Malaysia is coming up with a guideline how to do verbal autopsy among the relevant forensic people, doctors and whatnot. And I'm glad you came up with this document, because without the standardization at this level, it's very difficult to compare data that we have in the near future. So congratulations.
Thank you, Malaysia, for that intervention. Other? All right, Professor Lopez, would you care to respond to those two while others are considering their comments?
Thank you. The Solomon Islands indicate that the Brisbane Accord Group and our colleagues from the SPC, I've forgotten the new name, so I'll use the acronym, are here and have been close development partners, would perhaps have be able to elaborate more extensively than I can. But just from my own view, a country like the Solomon Islands really is at a point where it's in that inflection curve in epidemiological transition where you're moving out of communicable diseases to non-communicable diseases. And indeed, many of the countries in the Pacific, and perhaps many of the countries in this room, that is also likely to be the case. This is exactly the time when your governments, ministries of finance, other sectors of government, need to be better informed, more reliably informed about how fast that transition is going. What are the areas of resistance? What are the communicable diseases? Fortunately not Ebola, but many other routine communicable diseases are still killing many children and in some cases adults. And we're not having the success that we ought to have against these avoidable deaths. The health information system, particularly the vital registration system, will inform you about how far along that transition you are moving, what are the problem areas. Are you already seeing the emergence of tobacco-related mortality when you've got 50 or 60, or in some cases more, % of your male population smoking and having done so for decades? You are going to start to die in large numbers in your countries from tobacco, but you're not measuring it, and hence the policy response by countries, by donors, is not being taken seriously enough. So in the case of Solomon Islands, I just wanted to preface my response by reminding us all that this is not done just for statistical nicety. It is done to address a critically important pathway of human development, namely controlling disease and injury in populations. In the Solomon Islands, I would think the strategies around training doctors, and I know you're using the UQ tools, I'm delighted to hear that, but we're not doing enough, quickly enough, to train doctors in collaboration with WHO. Remember, this is ultimately a WHO responsibility. WHO develops the classification. It does a wonderful job in developing the international classification of diseases. We all collectively should be demanding more of WHO and its partners, even in academia, in the support to countries to apply that classification for public health purposes, namely the correct certification of the underlying cause of death. And this is what we ought to be doing in the case of Solomon Islands as well. So it's very good to see some progress along that pathway. I would urge you to demand and accelerate more progress for your doctors, using again the policy brief. The issue of what about deaths that are not being captured by your system is a very good point, and I think it's germane to many countries in this room. And my recommendation here, as we've laid out in the policy brief, is think about countries like India, like China, like Bangladesh, many of whom have created effective functioning sample registration systems. It's not the full population, but if they're well constructed and they're representative of populations that are not being captured in your civil registration system, then you will get usable data, as these countries have, for policy and planning. And I'd urge Solomon Islands and other countries to think about the same strategy. Secondly, to Malaysia, just to respond, it's a very important intervention because you reminded us that we've gone so far in the application of the WHO ICD rules and procedures, but we all could look more critically at what we're doing, i.e. the death certificate that is in operation in your countries. Is the death certificate in your country an exact mirror image of what the World Health Organization recommends? In many of the countries I go, and the first thing I ask, the answer is no. And it's simply because the public health importance
of this cause of death data has not been made clear enough to the medical establishment and the medical associations in your countries, and indeed the statistical associations. So it ought to be a responsibility of all of us concerned with strengthening vital registration systems to ensure that our medical associations are correctly collaborating and insisting with the statistical officers to use the WHO form of the International Death Certificate. It is, a lot of thought has gone into it. It has been in application for over half a century. It correctly allows doctors to identify the underlying cause against which prevention efforts should be made. Thank you.
Thank you. The floor is open for another round of comments. Please.
Thank you. And thank you, Professor Lopez. My name is Annika from WHO. I don't know whether I've been introduced or I wasn't here on Monday, I'm sorry. And I agree with Professor Lopez. WHO does indeed welcome a response from countries around the importance of cause of death in their countries and development in improving causes of death in their country. And I think I just wanted to note for countries that there's some good developments in and around causes of death, including automation of ICD that's available and freely available, and also some recent work on shortening verbal autopsy questions and some other work on the ICD tool itself and application as an interim step, which I hope my boss, Dr. Thies Boerma, will be here Friday and he might speak a little bit about that. I just wanted to ask or perhaps even clarify the message, Professor Lopez, because we are talking about a complex collection system, which I think we all know, and some responses from countries have actually identified that even just in this session. And some of the messages that we're getting about cause of death always being wrong, about verbal autopsy being unsustainable, but a better option than medical certification. I just wanted to get a sense of the message that you're giving countries about building their mortality systems, and especially from a national perspective.
Other comment? Carla, in the back, please.
Thank you, and thank you both for a very interesting session and presentations. My question is about timing, because I think you said, Alan, at the beginning, this is complex. And then I know we also, the 2015, the development of the post-2015 agenda, I mean, it's around the corner, it's tomorrow. And the pressure, the demand for data, including on causes of death, is huge. So, is it possible to highlight a pathway that countries can follow to be able to meet this demand, in a reasonable period of time? Because I think there are many things that they could do. What should they do first? Where should they put most of the limited resources? Because nobody has unlimited resources. And is it really possible to achieve results within a short time frame? I think it is, but I'd like to hear from you that this really can be done. It isn't quite as complex as may appear.
Any more? Bangladesh, please.
Thank you, Chair. My simple query, to Mr. Professor, that from his deliberation, what we can learn that this is a complex issue still, particularly country like Bangladesh, where we don't have the full medical coverage. And in case of birth registration, what we have seen that in the people are encouraged because it has been related to some socioeconomic benefits, socioeconomic services have been interlinked, and people are more encouraged. But what about this causes of death certificates? Whether the family members, how they can be encouraged to get that certificate or to know what really the causes of certificates, then it can we can get better benefits or better result from that. If there is anything that encourage the families or relatives to get to know the causes of death. That is my query. Thank you very much.
Thank you. In the interest of time, I'll take one more comment from India, and then we'll give Professor Lopez the chair.
I would commend the excellent presentation of Professor Lopez at the beginning. I do agree that education of the medical doctors is very important, because cause of death certification is probably one small part of their medical education, and the person who actually fills up the documentation after a death occurs is the junior most doctor, because the senior has too much on his hands. So strengthening the medical education part of it on the cause of death, very well highlighted by Professor Lopez. I would like to know whether there are, apart from the YouTube tools, can it be customized to local languages, and can we really make it, can we strengthen the medical education part of it? That is one. Number two, I found a contradiction in the presentation. On the one hand, we are talking about strengthening the cause of death certification. On the other hand, we are advocating the use of automated tools to get to the cause of death. Now, there are also a number of tools which are now in existence. So we do need a certification body which would certify the various tools available and recommend to us what would be the correct tool to use. Thank you.
Some very practical questions. For you, Alan.
Well, thank you all again for those observations and questions. I will try and deal with them sequentially. I think the response firstly to Annika Schneider's question about, well, what are we advocating here? I want to be very, very clear, and I want you to reflect back on to, when you read the policy brief, those countries in green. What is the common characteristic of Australia, New Zealand, Japan, and South Korea, and I could almost include Singapore then, apart from the fact of the cause of death list that Singapore used to report. But what is the common characteristic? They have every single death, or virtually every single death in those populations, are medically certified. The gold standard for correct and useful cause of death information has to be full 100% correct medical certification by doctors of every death that occurs in your population according to the WHO ICD standards. That is the gold standard. That is what we would be advocating. That is what we are advocating. And it is not an either-or. It's not, well, should we use verbal autopsy or medical certification? The goal has got to be what you are here for. 100% of your deaths registered correctly by age and sex, because that alone is important policy information, and correct certification of the cause of each of those deaths, which is the fundamental input into any public policy or global monitoring of development goals, MDGs and so on. So I hope I'm clear about that. Carla Abuzar asked about a very good question about, well, if this is complex, what can countries do? I don't want to overemphasize complexity here. It is more complex than the mere fact of registering the fact of death or the fact of birth, which is what the civil registration systems are doing, along with those essential policy characteristics such as the age of the mother, birth weight, and of course age and sex at death. Cause of death adds a layer of complexity because it involves the medical establishment. I'll come to that in a moment. But it is not an impossible or intractable level of complexity. It is manageable. Many countries have done it. Many countries are rapidly integrating that medical component, that medical perspective, into their civil registration systems as a critical part. We don't here in this room talk about births and deaths. We talk about births, deaths, and causes of death. And it's important that we understand cause of death is fundamental
in strengthening civil registration and vital statistics systems. It is complex. It would be incorrect to deny that it adds a layer of complexity, but I want to downplay that complexity and not equate it to impossibility and a reason for inaction. The minimal set of interventions that we might see, I urge you to read the policy brief carefully and see what is feasible and doable in your country with donor assistance, with technical assistance that I'm sure the Secretariat here can arrange for to assist you. In my view, it would be immediately intervening with the medical establishments to ensure that those deaths that are captured in hospitals, and even in the poorest of your countries, at least 10 to 20% of deaths are being captured by hospitals, that they are correctly certified, that doctors understand their role in generating important and critical information for public policy. It's not just a duty. It's not just an obligation for doctors who give it to junior doctors at midnight to do. It ought to be done correctly, and the medical records practices in hospitals ought to be up to standard to ensure that it is. So that would be one thing. The second thing I would do, where you understand that there are populations that are just not feasible to reach in terms of A, the registration of all the deaths, and B, the medical certification of the deaths, engage in using the new verbal autopsy methods as an interim measure to generate useful policy data on the causes of death for those largely neglected populations who require, perhaps more than any other sector of your population, policy intervention. Those would be my strong recommendations for minimalist interventions. There are many others that you could do. The question from Bangladesh about what is it that might encourage families to seek and demand information from the government about the causes of death of their loved ones and their family members is a very good one. We do not have the same inducements for registering deaths or indeed certifying deaths correctly to the individual that we have for registering births. They simply don't exist. There's some financial gains that might come from insurance for some fraction of the population, but by and large, in Bangladesh and indeed many populations, the families do not understand the importance of demanding a correct cause of death. Not for legal purposes, not for hiding causes of death that might be embarrassing. Those are fractions of the universe of causes of death that you'll deal with. The vast majority of the causes of death that you deal with do not have an inducement associated with them, but they do have a public policy benefit, a strong public policy benefit and a strong public policy role. And I think it is that countries ought to be, families ought to be pushing for, as long as this requires an awareness campaign. I'm not saying these can happen without a parallel campaign to get countries to take this seriously, to get families to demand this information, not only for their loved ones who have passed and so they understand more about the causes of that death, but for preventing other deaths in their families that might well occur from the same set of circumstances. And finally, for the intervention from India, you're absolutely right. In most countries, and probably including my own, it's the junior doctors at midnight that are being given the task of certifying the cause of death. And that's an indication of how seriously we currently are taking this critically important and largely neglected aspect of a civil registration system. This practice ought to stop. You're absolutely right. It requires greater engagement, and this is where the complexity comes in, greater engagement with the medical establishment, with the colleges of various physicians in countries to ensure that medical schools are devoting the essential curriculum, the 1 hour, whatever it takes, or 1 week or 1 day, whatever can be gouged out of the medical curriculum to ensure that doctors do not leave medical school without understanding the importance and responsibility that they have to development of their societies. And finally, it is not a contradiction of medical certification versus verbal autopsy. It is not, repeat, not an either-or. If we cannot achieve full medical certification, and it's understandable that that will take time in some countries, we need to have information on causes of death of those populations that are not being served. There is only one viable option, and that's verbal autopsy. There are many approaches to verbal autopsy. I'm sure Dr. Bormer on Friday will give you another set of techniques for verbal autopsy. I urge you to engage in the science, to engage in the evaluations, and choose those methods that are most applicable for your country. Thank you.
Good. Thank you, ladies and gentlemen. I hope you found our session interesting and informative. I appreciate your attention given to the discussions. The policy brief is available on the tables just by the door outside. Please pick an issue up on your way out. We have additional copies available at the APO Secretariat. Happy to send you some more through the post. So with that, our session is concluded, and thanks again to the organizers.
Excellencies, distinguished delegates, ladies and gentlemen, thank you to the speakers and delegates for such a sobering and thought-provoking special session. There will now be a short transition before we resume item 4 of the agenda, implementation of the Regional Action Framework on CRVS in Asia and the Pacific.